Hey everybody, I just wanted to give you a couple pieces of clinical pearls here, and it's actually with a patient that I've seen on and off over the years, and he ranks pretty much as my all-time top five. I've got a bunch of them currently. Actually, they keep making the hit parade, so to speak. It's crazy, but this is shows you the power of really listening and digging in deep. So I don't usually have patients fill out body regions. I actually do it. I fill it out as I'm talking to them in the narrative. So if he were to have filled it out himself, he would have filled out his right foot, his left foot, his right hip, his mid-thorax, and his C-spine. That's 5 regions of the body. And you're like, Erica, but I'm not treating 5 regions of the body, nor should you, right? Or nor should I, and I did not. In his story, he was telling me that when he worked on his right foot, when he rolled the ball, or when he released his anterior tibialis, that would actually make his foot feel better, right? But really nothing else. And then when he did the same to his hip, he would stretch his hip out. He would, do some rolling with the ball, do some exercise. He actually felt freer and better, but nothing else got better. Like the foot didn't get better. It's just his hip. So treatment to the local area got those regions better. It should, right? It didn't help his distal thorax pain or his stiffness, and it certainly didn't help his neck. And he's the kind of person that, if you move them the wrong way, they're like completely twisted, so to speak. Very sensitive systems. So in a scenario like that, I would urge you, and this is what I did because I wanted to talk about the exercise progression. And you need to prove to yourself or prove to them that those regions are linked. Clearly, they're linked. But you need to prove that they're going to make those other regions better, the thoracic and the C-spine and the region that they're not treating. So there will be, especially with the hip and a foot, a direct connection neurally or fascially, or muscularly, neuromuscular, between those areas. So in terms of treatment, you would literally have to, if those were your drivers, and those were his drivers, foot more primary, but hip very close. And so I'll just take an aside for a second. In my clinical practice, I would say 10 times out of 10 in these more subacute chronic or persistent population, I always treat more than one region. I would say probably 2. Because they've compensated for so long, for so many years, their bodies have learned to adapt, right? And it's generally not one region. You'll have one region that'll give you the most bang for your buck, but there's going to be another region that you're going to have to treat to take them home, so to speak, right? So with this particular patient, I actually had to treat both of those in the same session because I'm not going to go into the details of the assessment because I wanted to go in, as I said before, into the exercise, but he was very into exercise and working out. And so I ended up treating the foot, the hip in the same session. I do a lot of dynamic release, and you will have heard me talk about that in other videos. So suffice it to say, I had to treat both in order to get everything better. So in the assessment, I actually corrected his right hip and his right foot in a squat, and I used his squat as a meaningful movement tool, and he felt so much better. So briefly, in explanation here, I did treat both of them, okay? And I can go into detail in a later video, but I want to talk about, so he was moving along, like for example, a squat is very, assuming those are the drivers, right? That you have 2 drivers, the foot and the hip. Foot more primary at this point, but at the beginning it was both together. If you give the person a squat, it's pretty easy to do, right? It's easy for the hip. It's a flexion moment, flexion extension, dorsiflexion, plantar flexion, or fan and fold for the foot. Very low load. I mean, not low load, but easy. It's neutral, right? I would say 3 weeks after the initial evaluation, he was improving, moving along. He started to do lateral lunges. And I was like, why did you do that? I didn't give you that. He's like, I know, but a friend of mine told me to do them. And I'm like, why did you listen to your friend? Anyway, it happens. It's life. He was worse, right? Why do you think he was worse? Number one, it was too early to do that. A lateral side lunge is really hard for a hip You're literally almost moving into one-legged standing. One-legged standing is supremely hard for the hip. So a lateral lunge is a little bit back from that, but it is certainly harder than a squat, right? And then for the foot, that's an inversion and eversion moment. That is also hard for a foot to do, hard for the region of the body. So because he had two drivers, and he did an exercise that made both of them worse, he was way worse. So I want you to think about that when you're doing exercise prescription.